Awesome. Can you see my slides? I started the sharing. You are sharing, screen
Yes.
sharing, and you see my title slide there?
Yes.
Oh my gosh, I love it when things come together. Okay, well, thanks everybody. I'm really excited to be here. Thanks to the organizers of the West Coast Vascular and Interventional Society. We'll get started. So osteoporosis is a huge problem around the world. It affects, 54 million people in the United States. It's projected to grow in scope over the next several decades. Very notable people, as you can see on the screen, have a diagnosis and are dealing with osteoporosis. The electron micrograph there shows you on the left-hand side the abnormal bone structure. So a combination of bone density and quality leads to bone strength, and ultimately osteoporosis is a slow loss of both of those components. You see widening of the trabeculae, loss of trabecular struts, holes in the struts, and ultimately you get failure. It's not just a disease of Caucasians, but it is typically thought of that way, and a lot of the marketing campaigns are really targeted towards whites, but this is also a problem in all ethnicities. Black women have a lower prevalence of osteoporosis due to a statistically significant higher bone mass, but they unfortunately have worse outcomes after fractures. And so we still have ethnic and racial disparities that need to be tackled. So as I mentioned, osteoporosis affects over 54 million Americans aged 50 years or older, accounts for 700,000 vertebral fractures. Once you have a fracture, we see that about 70,000 admissions occur, and those admissions can be long. You start consuming healthcare at 14 times the greater than the general population, and the cost to society is massive. Unfortunately, once you have a fracture, we know that there is a rapid deconditioning. We're frequently talking about elderly patients who are sort of at risk to begin with. Pain lasts on the average of 4 to 6 weeks, but greater the deformity leads to greater pain and greater disability. You get a downward spiral of decreased appetite, weight loss, difficulty with self-care, loss of self-esteem, ultimately loss of independence. And we know from very good data that there's excess mortality with the first fracture and every successive fracture. So this really
sort of explains it. So once you have
sorry about that. That should have deleted that guy. This is what happens to these patients. So you see this patient that I took care of who has this fracture in the lower thoracic spine. You can see the kyphotic angle that's centered there. You see that this progresses over time, and there's more and more progressive fractures in that spine segment there, the thoracolumbar junction, which is the most susceptible area of the spine. And look at the kyphotic angle over time, despite a vertebroplasty being done. And so the tragedy is sort of letting a patient go from a relatively normal spinal alignment to this profoundly kyphotic alignment that really leads to all that morbidity and mortality that we talked about. So preventative, these should be well understood by all, but calcium, vitamin D, fall prevention, tobacco and alcohol are large contributors to osteoporosis. And in the positive, resistance exercise is important to maintain bone mass. This is that patient we talked about. So traditionally, most clinicians had been providing symptomatic relief rather than something more aggressive. And so pain medicines, bed rest leading to more osteoporotic resorption of the skeleton, external bracing. And ultimately, though, we want to intervene on these people earlier. We want to, if they're appropriate, offer vertebroplasty or vertebral augmentation. Rarely do these patients need surgery if they have neurologic deficits. And you can see that the medications for osteoporosis have dramatically improved with the bisphosphonates, the zoledronic acid, the anabolic bone steroids such as teriparatide and calcitonin. But my question to everybody is, if we know that the Colles fracture on the right-hand side, we know exactly what to do with that one, right? So we're going to surgically fix that or cast that every single time. You're never going to leave that fracture alone. So why do we even have a question about the vertebral fracture? So this is sort of the big disconnect. And I think those of us that really are passionate about this space really push for earlier intervention. So I was part of this multidisciplinary, multi-specialty society position statement way back in 2014 that really pushed for the appropriate offering of vertebral augmentation in patients that are failing medical management. There is even more data recently when you look at this pooled data of over 4 million lives in this 100% Medicare data set where they look at all patients with vertebral fractures. It is clear that if you offer non-surgical management versus vertebroplasty versus balloon kyphoplasty, the non-surgical management group has a higher mortality. And there's a protective effect on mortality when you offer vertebroplasty and when you offer even more so with balloon kyphoplasty or vertebral augmentation. And you can see that the follow-up here is quite significant. So this is very powerful data. And this is your elevator speech for any non-believer that there's, data with over 4 million lives proving that non-surgical management really should not be the primary way that we treat these people. More recently, there's been systematic reviews and meta-analyses. And then one of the most compelling articles was by a good friend of mine, Josh Hirsch, and Doug Beal and others, which was a number needed to treat methodology, looking at vertebral augmentation and how many patients you would need to treat to save a life. And basically what we know from this is that vertebroplasty and vertebral augmentation compare very favorably. So the NNT is as low as 12 and as high as 23 for vertebroplasty and kyphoplasty versus non-surgical management. The bisphosphonates for reference are NNT of 50. Aspirin for cardiovascular disease and strokes is 67. So again, I think I've made the case that we should be treating these patients. So once they have failed medical management, they've had pain more than 2 weeks, pain that requires admission to the inpatient setting, or they're having complications of their pain medications, they become a candidate. We published a paper that really, if you want to take a look at this, uses RAND appropriateness methodology to sort of march you through the patients based on their symptoms, their imaging findings, and some unfavorable risk factors that you see here in the bottom left corner that help you to make these decisions about whether to treat. And there are some classification systems, the AO spine classification, as well as the Majuro classification system that sort of walk us through a simple impaction fracture or end plate fracture, split fractures, and then burst fractures with a increasing sort of prognostic implication. And so as you move from the top of the screen to the bottom of the screen, the fractures are more severe and the potential for failure of your construct, whatever you do, goes up. And also these patients that have these more complex fractures tend to have more pain. Well, we've had an evolution back in the earliest vertebroplasty was in the early 80s by Hervé Dermond at C2. In the 80s and early 90s, it was really just needles and mixing cement on the back table and injecting it into the vertebral body to provide an internal cast. There was evolution of the vertebroplasty kits with nicer cements and better needles. And then ultimately balloon kyphoplasty came along, and the hope of potentially restoring height and restoring alignment was born. And that's what we've been chasing ever since, is the ability to take a wedge fracture and try to actually realign the end plates. There's been further development with cavity creation devices, and now we are in the age of implant-based technologies. And so the Kiva, which you see on the right-hand side, and the spine jack are implants that go in to provide stability, and then the cement goes in to lock these implants in. So the game changer here is that the implants now are the structural construct rather than the cement. So here's a patient who has the bone scan with increased uptake at L4. You can see the MR with low signal at L4 again. We bring the patient into the lab. We perform AP and lateral views. We're going to be targeting the pedicle in this patient. And so you see the needle going into the pedicle on both the AP and the lateral view. Here's some anatomy that obviously you all are familiar with, but we're going to be targeting the pedicle. We line up the pedicles and the spinous processes, and then we basically are going to march the needle in, being careful on the AP view that we do not cross the medial plane of that pedicle before we get the needle into the back of the bone. And so the tip of this needle has to be in the back of the vertebrae before you see it cross that pedicle on that AP view that I just showed you. And so here you can see the final resting point of the needle for simple vertebroplasty. We start injecting the cement. You see this sort of fluffy disbursement of cement in the trabeculi, but you'll also see this more linear, angular pattern of cement, which is filling a cleft in the fracture and is almost certainly the source of the patient's pain. So happily, we've really advanced the technology. And so that procedure that I did was probably 15 years ago. This procedure was done within the last couple of years. So this is the spine jack. You can see the MR findings of high signal. You can see the cortical disruption of the upper end plate at L1. We bring the spine jack cannula in with the reamer and create the space. We deploy the spine jacks and cement them in, and notice that concave end plate has actually been flattened out very nicely. You get end plate restoration, improvement in sagittal balance, improvement in kyphotic angle. And so this is really where we want to go in the future. So the game continues to change. The V-strut is a PEEK implant that has the ability to inject through those holes into the vertebral body, but the back ends of these implants actually anchor you in the posterior elements. And so one of the things we know is that in those complex fractures that I showed you in the classification system, where there's a coronal split or there's a burst, the potential for the whole thing to fall apart is there. And so we now have these constructs where we anchor the vertebral body implant into the posterior element. So we're basically doing an at-level fixation, and that's what this technology is showing us. Finally, people are looking in Europe, because we don't have this technology in the United States yet, but basically this area here in the middle of the slide is called the middle column, and that's the weak area. And so with the SAFE technique, you basically put in your stents, you inject cement, and you anchor into those stents with these screws that stabilizes the whole construct. So this is, I think, where we're going, and there's some data that would suggest that this at-level fixation is as good as the traditional above and below fixation that the surgeons would do. So again, moving away from traditional surgery to minimally invasive techniques. So key takeaways: osteoporosis needs to be diagnosed and treated aggressively. There are, unfortunately, racial and ethnic disparities that we need to challenge and actually address. Vertebral augmentation decreases mortality significantly, and the NNT is quite low. Techniques continue to evolve. The implants are definitely the preferred technique, in my opinion, and biologic cements, now that we have those implants, are on the horizon. That'll do it for me. I'm happy to answer any questions.